This episode of Pupil Pod is supported by Dompe.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Dagny Zhu. Dr. Zhu is a refractive surgeon and practice owner based out of Los Angeles, California, and you can follow her journey and the adorable baby Addie on Instagram. Dr. Zhu, thank you for joining me tonight.
Oh my gosh, thank you so much for having me. This is such an honor.
As always, we'll get right into our case to save us some time. So this is a 37-year-old woman who comes to your office for a refractive surgery consultation. She has been reading extensively online and has questions about the different options available. Now, her first question is about the difference between LASIK and PRK. Dr. Zhu, can you walk us through the type of patients you would choose for PRK over LASIK, and then maybe some of the limitations of each of the procedures?
Sure. So for the basic, typical, normal patient, I go to LASIK. That's my go-to refractive procedure. And the reason is because it offers a faster recovery and because it's more predictable. I tend to be able to hit the outcome more reliably. Now, of course, for patients who are not candidates for LASIK, because usually they have a high prescription or their corneas are too thin, or it's just kind of an irregular, funny shape, which may be suspicious for underlying keratoconus or ectasia, then PRK is a great option. So the main difference between the two techniques is just the presence or absence of a flap and how we're able to access the stroma for excimer ablation. So with LASIK, we're using a femtosecond laser to create a flap. I can then lift the flap, access the corneal stroma, and use my excimer laser to, polish away the stroma according to the degree of prescription or refractive error that the patient has. Now, when patients have really thin corneas or their prescriptions are really high, or if they're irregular for any reason, you want to conserve as much tissue as possible. So you don't want to create a corneal flap. And so in those cases, the only way to access the stroma is to debride the epithelium, as in PRK. So the excimer laser that we use to treat the degree of, refractive error is the same with PRK and LASIK. But in PRK, because I don't have a flap, the surface of the eye basically has a large abrasion, and that epithelium needs to heal over. And so for that reason, PRK is a lot more uncomfortable the first few days because of the large abrasion there. And the recovery in terms of healing and also visual recovery is a lot slower than LASIK. So most of my LASIK patients can pretty much read the 20/20 line the next day. But for PRK patients, they usually take about a week or two to get to 20/20. And even then, it's a little bit fuzzy. And so I tell all my PRK patients that it could take up to 3 months for their vision to really stabilize and be as sharp as possible, because we have that microscopic epithelial remodeling those first 3 months. So because of the different techniques that we use in PRK versus LASIK, you also have different sorts of complications that could be related to each one. So for PRK, because we're debriding the epithelium, there's a risk of non-healing. So there's a chance that you might end up with a non-healing epithelial defect for a while, and that can lead to corneal haze that can be difficult to treat. Of course, that also leaves you more exposed and more vulnerable to infection as well. So there's a slightly higher risk of infection with PRK. And in terms of corneal haze, let me go back to that. It's higher with higher prescriptions. So I typically don't like to do PRK for prescriptions greater than -6. And I also don't like doing PRK for hyperopic corrections because of the risk of haze, but also because of the reduced accuracy. And so those cases, I definitely prefer to do LASIK if possible. Now, of course, there's complications related to LASIK because of the flap. And so some of those flap complications include, making an imperfect flap. So it might be incomplete, might end up with a buttonhole or even a free cap. You could have inflammation in an interface of the flap, infections in the interface of the flap, early dislocations, late dislocations of the flap. But those, luckily, overall, the chances of those complications are extremely, extremely rare. And so overall, both LASIK and PRK are very safe procedures, but each has their advantages. But in general, LASIK is my go-to preferred procedure because of the quicker visual recovery and also because of the accuracy. So one reason that PRK may end up being a little less accurate is because as that epithelium is healing, it's pretty unpredictable. And some patients, their epithelium doesn't go back to the same thickness as before. It might heal a little bit more hypertrophic, and they end up with thicker epithelium that leaves them with residual myopia. And so for that reason, I can't control it. I can't control an eye, the patient's healing. And so because of that, it's a little bit less predictable. And so that's another reason that I prefer LASIK for most cases. And of course, it will depend on the patient's lifestyle. So if they're like a Taekwondo artist and they have a really high chance of blunt trauma to the head or the eye every day, then again, I would stay away from LASIK because of the risk of flap dislocation. So deciding between the two procedures is going to depend on, the patient's preference in terms of their lifestyle and their hobbies, but also how much time they have to take off, and also based on the anatomy of their eye and the overall prescription that we're trying to treat.
So let's just say that our patient was not a Taekwondo artist and was a pretty mellow person. What are some of the different methods for flap creation in LASIK?
Right. So it's so wonderful today that we have the femtosecond laser. So when I came out of training, I actually went straight to the femtosecond laser. And I think that's the one that most surgeons prefer to use these days. The reason being that it is just so consistent and accurate. So you're going to get a great quality flap almost every single time from the periphery to the center. It's going to be a uniform thickness. You can control the diameter of the flap. And so it just really assures me that I'm going to get a great quality flap at a thickness that I can control. Now, that's not to say that the microkeratome is no longer, used or gold standard even, because the modern day microkeratome has actually come a long way. And I've discussed with colleagues who use some of these modern day keratomes, and they say that, the quality of the flap is just as good, as a LASIK flap, at least clinically. And the complications that were associated with the older microkeratomes really are much lower these days with the modern day microkeratome. And so I can review a little bit about the microkeratome just because I know that some of you will still get tested on it in terms of your exams. But the microkeratome basically comes with a suction ring. And the suction ring has two main functions. Is to adhere to the globe so that you can have stability for the microkeratome cutting head to create the flap. And then number two, the suction ring raises the IOP to a high level, which stabilizes the cornea and allows for a more precise creation of the flap. The tricky thing with using a microkeratome is you have to match the ring size and diameter to the curvature of the cornea to get the best outcomes. So for example, if a patient has a really steep cornea, usually 44 or greater, you have to use a smaller ring and you end up making a smaller diameter flap. And that minimizes some of the risks associated with a steep cornea, like a buttonhole flap. If you have a flatter cornea, you have to use a larger ring, and that makes a larger diameter flap, and that minimizes the chances of a free cap. And so, unfortunately, with the microkeratome, you kind of have to dictate your flap diameter based on the anatomy of the patient's eye. You don't have control over that. Whereas with the femtosecond laser, you can actually program exactly what diameter you want. You can choose whatever ring size or whatever diameter size you want. So some surgeons use 8.5 or 9.0 millimeters for all of their LASIK cases. And you can also program the thickness of the LASIK flap. So if I put in a 90 micron flap, I can be pretty certain that my flap's actually going to end up being 90 microns plus or minus a few microns. With the microkeratome, at least the older microkeratomes back in the day, very unpredictable what flap thickness you will actually end up with, because again, it has a lot to do with the curvature and the anatomy of the patient's eye. And so that's why back in the day when they did LASIK with the microkeratomes, after lifting the flap, they would actually check with a pachymeter the residual thickness of that residual stromal bed, just to make sure there was enough tissue for the ablation. But these days, I believe even with modern day keratomes, the flap thickness is a lot more consistent than back in the day. So it can be a lot more precise for that reason as well. I can talk a little bit about femtosecond laser and how that works. So basically, as you know, a microkeratome is just a blade. So you're mechanically creating the flap. But with the femtosecond laser, it generates these laser pulses, basically like thousands of laser pulses, all in the shape of a circle. And it does so through photo disruption of the collagen. And so the best lasers are the ones that use low energy, high frequency. So the greater the number of laser spots you have, the more the spots overlap, the better the dissection of the tissue, and the more easily that flap will lift with fewer adhesions. And so that's the type of flap that you want to get. And as I mentioned, the femtosecond laser is programmable, so you can adjust the flap diameter, the thickness, and you can even center it over the patient's visual axis after docking. The microkeratome, on the other hand, you have to get it during the actual docking of the microkeratome, and you have to line it up as best as you can with the patient's pupil center or visual axis. So the femtosecond laser, again, lets you have a lot more control over the creation of your flap in many ways because you can program a lot of those settings.
So you kind of have been alluding to this in the last few discussion points, but can you just review the complications associated with flap creation? So we talked a little bit about buttonhole and free cap, and maybe who is at most risk for that and what we do if those complications occur. I know that, again, they're really associated with the microkeratomes and we don't use those so much anymore, but for testing purposes and just for us to know as trainees, could you just review those complications?
Yeah, of course. So, even femtosecond lasers aren't 100% immune to those issues that plague the microkeratome. So a lot of the flap complications are just result from an imperfect flap. And so, as I mentioned before, with the microkeratome, a lot of that depends on the shape of the patient's cornea. And so for flat corneas, and when I talk about flat, they're usually, 41 or lower in diopters. Those are the corneas that are at risk of having a free cap. And one way to bypass that, as I mentioned, is to use a larger flap diameter. But the good news is that if it happens, with the microkeratome, it's really scary because that free cap comes off and it gets stuck in your microkeratome and you look down and it's like missing. And so don't freak out, look in your microkeratome, look at the actual cutting head because a lot of the times it's in there. And so you have to carefully salvage that flap, remove it, and kind of iron it out, put it in a moist chamber to preserve it, keep it sterile. And you can still go ahead and do the ablation on the corneal stroma. And then once that's done, you can actually put the flap back on. Hopefully you've marked the flap ahead of time. And I actually mark all of my flaps just in case we have to reposition a flap, just to make sure it's perfectly aligned. So if you have those markings, then you can align the free cap perfectly over the stromal bed in the orientation that it was before this happened. And then that's usually enough. The endothelial pump is usually sufficient to keep that flap adhered to the stroma. And you don't actually have to put a suture in to keep it in place. And then I would just use a moist weck and kind of, gently polish it and kind of apply a little bit of pressure so that it's in place. And then you can apply a bandage contact lens, patch the eye, and all will be well, usually the next day. This is a very rare occurrence with the femtosecond laser, but I will notice sometimes that even with the femtosecond laser, If my hinge is not wide enough and the cornea is fairly flat, you end up with a flap having a very small hinge. But you can see it before you lift the flap. You can see that the hinge is small. So you're very careful when you lift the flap because you don't want to disturb the hinge and rip it off completely. Unfortunately, with the microkeratome, you don't have that ability to visualize it before you do the ablation because it just comes right off sometimes into the microkeratome head. But that doesn't happen with the femtosecond laser. So you can usually visualize whether the hinge is missing or not, or very narrow. And so you can just be very careful. So in those cases, again, with the femtosecond laser, you can program the hinge so that it's wider. If you're doing LASIK on a flatter cornea, I usually program the hinge so it's a little bit wider so I don't have that same risk of a free cap. So that is flat corneas. And the way I used to remember this for boards was, flat cornea, free cap, F and F. So that's how I remember, flat and free. So the opposite problem is in steep corneas, and that's when you can get buttonholes. And you can think of why that might happen. If your cornea is really steep, as you're applanating with the femtosecond laser, it's kind of squishing the collagen. And so you're at higher risk of creating an imperfect flap with irregularities, including buttonholes. And so buttonholes are okay if you recognize it. So after you pass the microkeratome or the femtosecond laser, you might not notice the buttonhole right away, but when you go to lift, you'll see that there's a hole in the flap that you're lifting and it leaves behind a little residual piece of the flap right in the center usually. And so when you see that, just gently replace the flap back down and just again with your moist Wexel, kind of just apply gentle pressure, get everything back in place, nice and water sealed, and don't do the ablation. Put a bandage contact lens, let the cornea heal, and then you can come back to it several weeks later to do PRK on top, or you can even try to attempt to create a new flap several microns thicker than the original, so you go deeper, and then you can still perform LASIK safely. So if you were to lift the flap with a buttonhole and still do the ablation, then you would get a very irregular ablation because you would be ablating that residual piece of flap stroma and epithelium that was stuck on the bed. And that would lead to, irregular astigmatism and loss of best corrected vision. So as long as you recognize it and lay the flap back down, let it heal, the cornea is pretty resilient. And so you can always go back at a later time to do your treatment. So we talked about free caps. We talked about buttonholes. The other common complications are usually associated actually with the femtosecond laser. And so there are specific things associated with that we don't see with a microkeratome. For example, sometimes you get an opaque bubble layer, which is basically after you've created the flap, you see this really dense white confluent layer of bubbles. It just looks really white. And when you go to lift the flap, it's really tough. It's really stuck down and you can't easily lift it. And even if you do lift it, the pupil tracker can't visualize the pupil through that opaque bubble layer. And so you can't proceed with ablation. So in those cases, the best thing to do is just, again, lay the flap back down, or if you see an opaque bubble layer, try to massage out the bubbles as much as you can underneath the flap. If it doesn't work, then you just go to the other eye and just let that eye kind of just let those bubbles dissipate. And so after you wait, a while, 30 minutes, sometimes even an hour if you have to, the bubbles will eventually go away and you can go back and lift the flap. And so the great thing about that is there's no risk of vision loss. It's just kind of a nuisance, but you can definitely overcome it. Same thing with anterior chamber bubbles. That's something that you can get with only the femtosecond laser. And again, it can get in the way of the pupil tracker. But again, if you just give it some time, those bubbles will also dissipate and you can go back and complete the procedure. So again, the complications related to the femtosecond laser is more of a nuisance rather than something that's more sight-threatening, which is something that we had more common with the older microkeratomes, because free caps and buttonholes, those are definitely a lot more concerning.
This episode of Pupil Pod is supported by Dompe.
So the idea of lifting a flap, I think as a trainee seems scary at first, but then we often lift flaps for enhancements and retreatments. Can you talk a little bit about when that occurs for each different type of refractive surgery and kind of what you do in your practice?
Sure. So I prefer to do a LASIK relift enhancement whenever possible. So if a patient has had LASIK, they're usually stable even at that first month, but I like to wait at least 3 months just to make sure nothing is changing. And if we find that there's some leftover prescription, it's pretty easy to just go back and identify the edges of that flap right under the microscope. And I will also mark the edges of the flap. So when I lay it down, it's in the perfect position. And I'll just use a Sinski and just go along the edges to gently lift up the edges of the flap. And then I'll use my dissector or spatula to lift I use a pair of forceps to gently lift the flap all the way from the stroma of the bed. And then at that point, you can just do your ablation normally, and then you want to gently lay the flap back down. And that's probably the most important part, is when you're laying the flap back down, you want to make sure that everything is smoothed out. You don't have any epithelium that is, kind of debriding. And so I always try to put the epithelium kind of back in place if there's any that's loose, because there's a high risk of epithelial ingrowth when you're relifting an old LASIK flap. That's the main complication of that. But if your edges are good, you're not disturbing epithelium, you're pushing aside any loose epithelium that you do see, and if the relift is done, relatively in the early postoperative period, the chances of epithelial ingrowth are pretty low. When you're lifting older LASIK flaps, especially flaps that weren't created by you but a different surgeon, there's a much higher risk of complications. So lifting older flaps, the epithelium is more raggedy, the edges of the flap are more raggedy, so you have a higher chance of epithelial ingrowth. But you also don't know what happened to that flap. It could be a free cap flap. It could be a partial thickness incomplete flap. So you don't know what you're lifting. So definitely take some courage to lift older flaps from other surgeons. But I definitely have done it because I prefer the accuracy and precision of LASIK relift enhancements. So the other option would be to do PRK over an old LASIK flap. But the problem with PRK over an old LASIK flap is, again, the epithelium regeneration is really unpredictable. And so you may not be able to hit the target as you would like. And sometimes you're debriding their old epithelium that has really hypertrophied, and it's really thick, and then it doesn't grow back as thick, and then so you've overtreated the patient. And so it's just a lot less predictable when you're doing PRK over LASIK, and I actually don't prefer to do that. So I relift very carefully whenever possible, acknowledging that there's a risk of epithelial ingrowth, which can also be treated. You can relift the flap, remove the epithelial ingrowth, and then lay the flap back down and apply Tocil glue to the edges, or sometimes you can even place sutures, and that really stops the epithelial ingrowth from recurring again. So that was for LASIK enhancements. For patients who've had PRK and they need an enhancement, I would definitely wait at least 3 months, if not 6 months, because again, that epithelium is healing over time. And so you might continue to have refractive changes even those first 6 months. And so for PRK, I usually like to wait at least 6 months before I do an enhancement. Overall, the enhancement rates for both LASIK and PRK are pretty low. So in my practice, I would say less than 5%. But of course, it's going to be higher for cases of really high myopia, as well as for cases of hyperopia and high astigmatism. And even more so for PRK. I think the chances of regression are higher with PRK as well. So in all of those cases, you should counsel your patients that, there's a chance that we might not get it all, or some of it might come back and we'll have to do an enhancement down the road, which is, for the most part, very doable.
So stepping back a little, can we just review the other epithelial preservation techniques like LASIK and epi-LASIK? I know that these terms get thrown around a lot, but we don't usually get a lot of exposure to these procedures.
Oh, sure. I remember this was on our boards, and I used to be so confused about PRK versus LASIK versus epi-LASIK. It was like extremely confusing. Now that I actually do refractive surgery, I can clearly tell you the differences. Okay, so hopefully that you find this helpful because I myself have finally discovered the answer. So, so we've talked about LASIK, in which you have a flap. So PRK, LASIK, and epi-LASIK, they're all under the same umbrella. So there's no flap, there's no stromal flap. They are all considered surface ablation techniques. And the difference is what you do with the epithelium. So with PRK, we're basically getting rid of the epithelium. Usually we're debriding it after applying alcohol or using a special brush, and we're just getting rid of it completely. For LASIK, we're not completely getting rid of the epithelium. We're just gently pushing it to the side. So you can use like a wet cell filled with dilute alcohol, hold it over the cornea to loosen up the epithelium. And instead of just scraping off the epithelium, you're going to use like a special instrument that just pushes the epithelium to the side. And so it's still attached by a hinge. After you do the ablation, you can use another instrument to gently spread that epithelial flap back in place. And so it acts as like a covering or a bandage, and then you put your bandage contact lens on top of that. And so the only reason that we do that is because there seems to be, in some cases, faster healing and a little bit more better comfort when you're laying the epithelium back over the bed after ablation. I actually do LASIK in my clinic over PRK because I have found that patients seem to be a little more comfortable day one with LASIK compared to PRK. But, you know, the research and what we've seen in literature, it's very mixed. Like some studies have shown there's really no difference in the comfort level or the overall healing time between PRK and LASIK. So most people just do PRK. And when I can't get a good epithelial flap because sometimes it just like disintegrates or the hinge breaks off, I just convert to PRK very easily, and I'm not worried. I know they're still going to have a great outcome. So that's LASIK. Epi-LASIK is very similar to LASIK because you're preserving the epithelium, but you're, instead of using dilute alcohol, you're using like a very special microkeratome that can basically create an epithelial flap, like a very thin, precise epithelial flap. And then you push that aside, do your ablation, and then you lay your epithelial flap back in place, just like LASIK. So you're just using a different technique to create that epithelial flap, and that's the only difference. And again, the goal of both is to maybe decrease postoperative pain and maybe speed up the visual, recovery of visual acuity. But it's a little bit questionable if it actually works, because having that epithelial flap there, some people think it impedes the healing, and it's actually more uncomfortable because it's kind of denatured epithelium. It's not vitalized, and it's going to slough off eventually anyway. So just having that there may be actually more uncomfortable and may actually decrease the healing. So who knows? At least subjectively, I feel like LASIK works well for my patients. They're pretty comfortable, but the studies have not necessarily shown it. But hopefully that was helpful and actually gives you a better idea of what the difference is. Okay,
it's
good.
Such little exposure to it, but it gets tested all the time. So
which is so silly, because no one does it anymore, really. I think I'm one of the few that still does LASIK.
But it's nice to hear that you actually do it and have great results for your patients.
Yeah, I was actually a little bit skeptical about it because I bought a practice and that's what they were doing. And so I just continued to do things the way that they did it. But I was like, is this really more comfortable than PRK? But to be honest, I actually felt it was, because I remember in fellowship a lot of phone calls overnight, with our PRK patients. And with LASIK, like not as much. But, there are a lot of other things you can do also to decrease pain with PRK. So you can use an NSAID. That helps, the first few days. And some people even dilute, some anesthetic drops, like a comfort drop. And that seems to be helpful too. So there are ways to get around the pain. But overall, I think PRK is a lot more tolerable these days than in the past, where you just had to deal with it. I think we do a lot more things that help our patients now.
Yeah. Okay, so now shifting gears to newer advances in refractive surgery, can you tell us a little bit about SMILE, kind of how it compares to LASIK or the different types of surface ablation?
Yeah, Smile is such a wonderful new technique. So, um, as you may know, instead of creating a LASIK flap, you are using a very special laser to create a lenticule that bypasses through the epithelium into the stroma. And based on the patient's prescription, you create a thickness, a lenticule of specific thickness that you can then remove from a very small incision in order to improve the patient's vision. So the mechanics of it, it's a lot better than LASIK because you're not cutting an almost 360-degree flap. You're not severing those nerves, many of which you do when you create a LASIK flap in the anterior stroma. And so because of that, the benefits of SMILE is that you get less dry eye because you're not severing as many of those corneal nerves, but also greater integrity. And so because there's no flap, there's no risk of dislocating a flap. It's a lenticule that you've removed from a tiny incision. And so there's really nothing there to dislocate. So it's a great option for patients who perhaps you're worried about dry eye disease, but also for patients who have a more active lifestyle. They're more likely to get hit in the head like our Taekwondo artist. And so I think that SMILE is a great option and alternative to LASIK for those particular patients, especially based on lifestyle. The dryness, I think some studies have proven that SMILE seems to reduce dryness compared to LASIK, but other studies have been also equivocal. And I've spoken with some of my colleagues who do both, and they've not always seen less dryness with SMILE either. So it's not something that you can just do in every single patient. You want to assess the dry eye status of every refractive candidate, and you want to treat it appropriately, even if you're going to do SMILE. So because SMILE, again, it's still a procedure where you are disrupting the cornea, you are disrupting nerves, so you're still going to get some dryness. And so you don't want to do it haphazardly. You still want to make sure you're doing it in the right patients and that their dryness is properly treated. Another myth, or some, maybe not a myth, but misconceived notion about SMILE over LASIK is the decrease in ectasia rate. That actually has not been proven, but it was always thought about theoretically because we're not creating a flap. Perhaps, SMILE eyes have greater mechanical integrity that leads to lower rates of ectasia. But I think there was a recent paper that just came out comparing rates of ectasia in LASIK versus SMILE, and it was actually equivalent. Not statistically significantly higher for LASIK, and maybe even the numbers for SMILE were a little higher. I can't recall the exact numbers, but it definitely did not support lower rates of ectasia with SMILE. And so when it comes to screening, you want to employ the same screening guidelines that you do for LASIK for SMILE. You're not going to have a lower threshold for using SMILE, because really we don't have that data that shows it decreases ectasia rates. So I would still be very careful about that. And if there's any suspicious signs on topography, I would just fall back to PRK or no surgery at all.
Okay, well, we've definitely covered a lot of really important and I would say high yield content. So just to summarize a little bit, everything that we've learned from you, Dr. Zhu. We have the epithelial preservation techniques like LASIK and epi-LASIK that keep an intact epithelium, but maybe have some mixed results when compared to PRK. PRK and LASIK are still the leading refractive procedures, with PRK being favored in certain eyes, like eyes with irregular or thin corneas, people with a history of previous corneal surgery, people with high myopia, or lifestyles that could result in flap complications like our Taekwondo master. LASIK flaps were traditionally created with a mechanical microkeratome and were associated with rare complications like the free caps with the flatter eyes, the F for those of us taking our boards, and then buttonhole flaps in steeper eyes. Now, femtosecond laser flap creation has fewer complications and is often the preferred method for flap creation today. Enhancements may be needed in up to 10% of cases. Dr. Zhu, you said for you it's a little less, maybe around 5% or less, and often involves lifting the flap and ablating the corneal tissue. And then the most recent refractive procedure, SMILE, involves the creation of a small incision and the removal of a stromal lenticule, with early studies showing that results may be similar to LASIK, but without the creation of a flap.
Yeah, that's a great point. Actually, I forgot to add about the visual outcomes. I think they're pretty similar. I will say that the healing is a little bit, the visual healing, visual recovery is a little bit slower with SMILE. And I think a lot of that has to do with the mechanical dissection of the lenticule, which is honestly really hard to do. There's a much steeper learning curve for SMILE versus LASIK. But once you've got it down, like I think the visual recovery for SMILE is almost the same as LASIK. Like I know our overseas colleagues in Asia, they've been doing SMILE for a long time and they actually have their settings more optimized than we do here in the US. They're allowed to optimize their settings more. And so I know a lot of SMILE surgeons there who get 20/20 SMILE outcomes on day one. So it's definitely achievable. But I will say the one benefit of LASIK, though, is the ability to do topography-guided LASIK. And that really treats higher order aberrations and gets you even better visual quality. So we don't have quite that capability with SMILE yet.
I like the... It is exciting.
Exactly.
It's nice to hear that, you know, some of our colleagues overseas are able to get similar refractive outcomes, and that we'll continue to see technology advancing and the surgical technique advancing. So it's good to kind of follow this history from LASIK and epi-LASIK all the way to SMILE. Dr. Zhu, before I end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Because we're talking about refractive surgery and optics, like if I could have dinner with someone, I would have dinner with Goldstrand of the famous Goldstrand model eye. He is the father of optics, and I believe he's the first and only ophthalmologist to ever win a Nobel Prize. You don't know him?
No, I don't. But is this the model eye that we have to remember the like 5.5, 17.5
yes.
for all of the optics
yes.
specialists? Okay.
Yes.
Having PTSD flashbacks. Tell me more.
I don't think he would be a very interesting companion over dinner, but I would love to pick his brain on like how he even came up with that and how we can solve the problem of presbyopia. Like I feel like whoever solves the problem of presbyopia and accommodation, like maybe I would have dinner with Helmholtz too, to figure out that fountain of youth, because I think that's the one thing in ophthalmology that we're all trying to figure out. That's like the one thing that we're still missing. And so whoever can come up with that, they got the golden ticket. So yeah, I'd probably have dinner with one of those guys just to figure it out.
That is a great and extremely relevant answer.
I'm probably like the only one who gave like a technical ophthalmology answer. But yeah, I'm really in the zone right now with ophtho, so I can't even think of any wonderful poets or anything like that. But
I think those two would be a fascinating pair to have. They would probably be completely lost in their conversations.
I just want to have dinner long enough to like figure out the secrets of the eye and accommodation, and then bring it back to our market. Because yeah, I would love to be able to solve that problem.
Well, Dr. Zhu, thank you so much for joining us on this episode of the Pupil Pod.
Thank you so much for having me. It was a lot of fun. And I hope at least that we've been helpful with explaining some of the basics of refractive surgery and some of the technologies that we use today. So thank you so much for having me.
It was extremely helpful. And thank you to all of our listeners. See you next time on the Pupil Pod.